So hello everyone, my name is Bas Groot Koerkamp. I'm a surgical oncologist in Rotterdam, the Netherlands, Erasmus Medical Center. And I'm very fortunate to have the opportunity today to give a presentation about one of my favorite topics, hepatic artery infusion pump chemotherapy for biliary tract cancer. And in this Precision-BTC Network webinar, I'm fortunate to co-present with Maeve Lowery, a medical oncologist from Ireland, who, just like me, did a fellowship and was also a consultant medical oncologist in Memorial Sloan Kettering Cancer Center, where many of you will know that this treatment has been developed in the past few decades. So just to give you a perspective on EU-funded research, and honestly, I had to look up a few of these things myself, but the Precision Biliary Tract Cancer Network is a cost action, and cost actions are EU-funded network grants, where the objective really is to build consortia, and so on the one hand, it's a goal in itself, but on the other hand, it's a goal to move on to further collaboration. And in this meeting, we want to propose one such collaboration of team members of this Precision-BTC network. Because there's a unique opportunity, which is another EU-funded research line, the Horizon Cancer Mission. And the current cancer mission, there is a call with the very complicated title, Innovative Surgery as the Cornerstone of Affordable Multimodal Therapeutic Interventions Benefiting Cancer Patients with Locally Advanced or Metastatic Disease. And those of you who are a little bit aware of HAIP chemotherapy, Hepatic Arterial Infusion Pump chemotherapy, is that it's actually probably one of the few treatments that fits perfectly with this cancer mission call, because the pump is increasingly placed robotically, so that's the innovative surgery. The pump is always a combination with the standard of care systemic treatment, so there's the multimodal intervention. And the pump is always targeting disease in the liver. So the focus of this talk today will be locally advanced intrahepatic cholangiocarcinoma, but the pump can also target, and is probably even more known, to target colorectal liver metastasis. And the current call is a huge call that for each project, up to 10 million euro funding is possible. So I would like to thank the Precision-BTC Network for the opportunity to have this webinar, and one objective, of course, is to share the literature and the knowledge about this topic, but another objective is to find out if any center in the current cost action network would be interested to participate with their center in this Horizon Cancer Mission call. So I'd like to start with a patient, which is one of our patients that we treated in one of our HAIP chemotherapy trials. And this is a 65-year-old man with unresectable intrahepatic cholangiocarcinoma. And he presented in August 2019 with non-specific abdominal pain, no relevant past medical history. And he had a 7-centimeter tumor. I'll show you the slide, involving all the 3 hepatic veins, as well as the left and the right portal vein, so clearly unresectable. And moreover, there was multifocal disease, another argument not to pursue a resection. But there was no extrahepatic disease. The CA19-9 was normal, which is not always elevated, and the biopsy showed adenocarcinoma consistent with intrahepatic cholangiocarcinoma without any sign of metastatic disease. And at the time, we did not do default analysis of genomic alteration, but later on during treatment, this was evaluated, and this patient had no further targetable, commonly targetable genomic alterations. So this is the CT here. I just show you a few cuts. This cut shows that I mean, the liver is atrophic, all hepatic veins are involved, and this shows that also the main portal vein and the right portal vein are involved. So I'll get back to this case at the end of the presentation, but this is kind of the patient population we're talking about when we talk about intrahepatic cholangiocarcinoma and hepatic arterial infusion pump chemotherapy. So this is kind of the scope we'll talk about. I will first start with kind of the big perspective, the nationwide treatments and outcomes, and then Maeve will continue with systemic treatment and the rationale and how it's done. And then I will conclude with the most recent Pump 2 trial that we performed for this indication. So the Dutch Cancer Registry has pretty good data, and what I think is very impressive about is that many experts, many authors still say that periohylar cholangiocarcinoma is the most common biliary tract cancer, but in the Dutch nationwide data, currently intrahepatic cholangiocarcinoma is by far the most common biliary tract cancer. And if we look at the nationwide treatments, we collected all data consecutive nationwide period of 9 years, so 1,700 patients. So since this is an older cohort, because incidence has been increasing, this is only 200 patients per year. It's interesting to see that only about 1 in 5, 1 in 6 patients get a surgical resection. And this may be different in your expert academic surgical center, but then you need to realize that you probably not see all patients. About 15%, and I think this is the disappointing number, of those patients who do not get a resection, only 50% get systemic chemo for liver-confined unresectable disease, and about the same number of patients get systemic chemo for M1 disease. So the important thing to realize here is that 50%, half of all patients, only get best supportive care, and this is in a country with universal healthcare coverage, and primary liver tumors are centralized in only 6 centers. But nevertheless, we are unable to treat half of all patients at all. So if you then look at the nationwide outcomes, and obviously this is not to show that surgery is superior, but those patients that are eligible and selected to undergo surgery, they have a 5-year survival of about 30%. Other treatments are some rarely performed other local regional treatments like radiation and ablation. And I think important to see here is that half of all patients, they only get best supportive care, and they die rapidly. And I'll get back later to why they die so rapidly. We'll show that in the vast majority, this is the liver disease that kills people so quickly rather than a distant metastatic disease. And if we further zoom in a bit more detail on those patients who have liver-confined advanced intrahepatic cholangiocarcinoma in the Netherlands, a 3-year survival, and this is kind of a consistent number of about 3 to 5%, and this is in the GEM-CIS era, and Maeve will also discuss more recent data, but it's only 5%. And to me, this 3 to 5% is really the benchmark for any local regional treatment, including hepatic arterial infusion pump chemotherapy. And now for the next part of the presentation, I'm happy to give the word to Maeve.
Thanks, Bas. I'm delighted to be here. Just following on from that, I guess, rationale as to why we consider pump therapy in these patients. Looking at patients with liver-confined intrahepatic cholangiocarcinoma as compared to those with metastatic disease outside of the liver, we don't really see any difference in terms of response to systemic chemotherapy, conventional gemcitabine cisplatin chemotherapy, for example, in terms of response rates or overall survival. And what's notable is even in those patients, we don't really see long-term overall survival or durable responses, still down in single-digit percentage, 2 or 3% with our best systemic chemotherapy, cytotoxic chemotherapy alone. And of course, we're talking really about liver-confined cholangiocarcinoma, and even in these patients, real-world data with patients receiving palliative systemic chemotherapy, so SEER data, we can see even in the real world, our outcomes are even more poor in terms of 4.6 months overall survival. And again, 3-year or longer term durable survival down in low single-digit percentages. So when we look at data for liver-confined intrahepatic cholangiocarcinoma, fairly consistently again seeing overall survival rates at 3 years between 3 and 5%, and usually minimal to no patients alive at 5 years. So showing, if you like, the threshold that we can achieve in terms of longer term survival, even for those patients who have liver-confined intrahepatic cholangiocarcinoma. Now, of course, we have made progress over the last decade for sure, with recent approval of immune checkpoint inhibitors, durvalumab and pembrolizumab, in addition to gemcitabine cisplatin chemotherapy for patients with advanced disease. And this certainly has improved longer-term outcomes for a subset of patients with intrahepatic cholangiocarcinoma, although of course we still lack adequate biomarkers to correctly identify which subpopulations will in actual fact have that more durable response and longer overall survival with combination treatment. So the updated data from a TOPAZ-1 study now showing a 3-year overall survival approaching 15% for patients with intrahepatic cholangiocarcinoma receiving the combination therapy durvalumab with gemcitabine cisplatin, but still less than 20% in terms of more durable long-term survival. Of course, also a lot of progress made in targeted therapies beyond the scope of the talk today, but of course, we've had approval of a variety of targeted agents for subpopulations of cholangiocarcinoma, which has proven itself to be rich in therapeutic targets. Ivosidenib approved for mutant IDH1 cholangiocarcinoma, several FGFR inhibitors, of course, approved for those with FGFR2 gene fusions, now also targeting HER2, KRAS, BRAF, and rare fusion events. But again, what we see in these studies is a lack of longer-term, more durable responses, even to targeted agents, which may perhaps change in combinations with chemotherapy or immunotherapy going forward. But at the moment, again, not seeing a more durable, longer-term survival, even in patients with intrahepatic cholangiocarcinoma that's limited to the liver. And of course, the control of disease in the liver is extremely important. We know that, in fact, liver failure is the predominant cause of death for patients on systemic chemotherapy with liver-confined intrahepatic cholangiocarcinoma, confirmed by this large series. The majority of patients actually who pass from their disease, liver failure is in actual fact cause of death. So controlling liver disease in patients with advanced cholangiocarcinoma certainly has potential to impact in terms of outcomes and survival outcomes. Of course, curative resection is what we aim for in a lot of patients with localized disease, but we have to also remember that the cure rate in patients who undergo liver resection remains low, especially in those who don't have those favorable risk factors of smaller node-negative solitary lesions that are well differentiated. And of course, the chance of cure with larger lesions, multifocal disease, pre-differentiated disease, of course, somewhat less, and chance of cure estimated in some places to be less than 10% for all comers. So again, this liver-confined intrahepatic cholangiocarcinoma, what do we know about it? Is it different to those with extrahepatic disease? Probably not. We know the cure rate after resection remains low, and especially those patients with higher risk disease. Chance of longer term survival with conventional cytotoxic chemotherapy alone, very low, perhaps changing in the era of combination immune checkpoint inhibitor therapy, but again, lacking the biomarkers to identify which patients might benefit from such an approach. And remembering that controlling the liver disease is actually important in terms of patient outcomes and patient survival as well. So moving to hepatic arterial infusion chemotherapy, what is the rationale for that? Well, first, I suppose the basic principle we know is that HAI will deliver chemotherapy to tumors via the hepatic arteries. That exploits the tumor's arterial supply as compared to the normal liver's parenchymal portal supply. And by using fluoxuridine in this manner, we can achieve high intrahepatic drug concentration, so essentially a much higher concentration of chemotherapy within the tumor itself, usually with minimal systemic toxicity because of a very high first-pass hepatic metabolism with fluoxuridine. How is it done? Bas can explain this better, but it's via a catheter, which is placed in the gastroduodenal artery at time of surgery. Very commonly now, my understanding, done robotically. After placement, the position is checked in terms of lack of extrahepatic perfusion by a SPECT CT, and patients can usually commence chemotherapy approximately 2 to 4 weeks post placement of the pump, depending if there has been a liver resection or no liver resection, and cytotoxic chemotherapy between 4 and 6 weeks post placement, again, pending if there's been a liver resection and the setting in which it is being used. So today we're discussing the use of fluoxuridine in hepatic arterial infusion chemotherapy. That's what myself and Bas are most familiar with, and that is used commonly in the US at the moment. And FUDR is chosen because it's the ideal drug to use in this setting. About 99%, between 92 and 99% of FUDR is extracted by the liver during first pass metabolism. So we can achieve tumor concentration somewhere between 200 to 400 times higher than if the drug were given systemically, so intravenously. It's effective in a rather small volume, so less than 30 ml of solution, which makes it ideal for putting into a pump, which has only a small reservoir. It is co-administered with heparin to maintain catheter patency, and also with dexamethasone to minimize biliary toxicity. And FUDR, of course, is a metabolite of 5-fluorouracil, so we expect it to work in the same manner in terms of cytotoxic effect. So the pump, there are several different potential options for the pump treatment, but all the same basic principle within. There's a reservoir that can also be bypassed usually by a side port. There's a flow rate, which can vary between patients, also with altitude, with heat, other things, but approximately 1.5 cc per day. It's placed subcutaneously. It can be refilled percutaneously just by a nursing staff. It's rather straightforward to refill the reservoir. The typical treatment regimen would be FUDR in combination with heparin and dexamethasone, put into the reservoir for days 1 to 14. And then that is emptied at day 15 and filled with a combination of heparin saline solution for usually another 15 days, days 15 to 28. If the pump is not in use, then it can be filled instead with glycerin, and that can be left in for somewhere between 6 and 10 weeks, just to make sure it doesn't run dry. The dosing for the oncologists listening is somewhat different to how we dose cytotoxic chemotherapy in systemic setting. And it does require careful oversight and knowledge in terms of potential toxicities and in terms of the dosing paradigms in relation to liver enzymes in particular. So first, in terms of approaching calculation of the FUDR dose for the pump, is first of all to select the correct dosing body weight. And that is in particular takes into account whether the patient has an ideal body weight or is substantially overweight. And so for these patients, if their body weight is more than 35% above their ideal body weight, we use the average body weight instead. Otherwise, if they're not overweight, you can use their actual body weight. Then you calculate the full dose of FUDR to begin with. And this is a formula which, at least in MSK, was the formula they published upon, which is this. You can see here 0.12 mg per kg per day is multiplied by the body weight in kilograms. That's either the actual body weight or the average body weight. The pump volume in mils, usually between 30 mils, 35 mils, depending on the pump. And the flow rate in mils per day, between 1.2 and 1.3. In some pumps that varies and is given to you by the manufacturer. Otherwise, it can be in other pumps that. Calculate the maximum dose then, and that means that you calculate what percentage of the previous dose was given. So we never go up on the dose once a dose reduction has been made. That's a fundamental principle of dosing of hepatic arterial infusion chemotherapy. So if the last dose is a 50% reduction from the full dose, then the new maximum dose is 50% of the calculated dose. Never increase after a dose reduction for a patient. And then you calculate today's dose. That's the next one, Bas. And that is based on the bilirubin, the AST, and the alkaline phosphatase. And we will look at several values when evaluating that and calculating the correct percentage dose to be used for that patient's FUDR at time of filling the pump. First look at alk-phos, the AST, the bilirubin. It's a reference value is the day the pump was filled with FUDR most recently. Then the comparator values are those checked at time of pump emptying. So when the FUDR is removed and the heparin saline solution is put in. And then again, when they attend for redosing with FUDR. The higher of those values is used to determine the dosing. So if it were higher at time of pump emptying than it is they attend for the pump filling, then you use a higher number to calculate and use this algorithm in terms of what percentage dose you would give. And you can see there it is too complicated, but you have to be able to map out the liver function tests and be able to go back to be certain of your reference values, percentage last given, etc., etc. And using the algorithm, of course, if it's a high bilirubin, we're going to hold that because it can be indicative of potential emerging biliary sclerosis, and you give a high dose of dexamethasone into the pump. If it is a certain percentage in terms of AST or alk phos or lower bilirubin elevations, there is still potential to go ahead with treatment, but it may be dose reduced to 50%, to 25%, or sometimes you just go to 80% if it's a mild increase. And it is actually a calculation which is quite specific. It's not like when we dose reduce patients in systemic chemotherapy setting, which is frequently perhaps it's diarrhea, maybe it's grade 2, and we'll say maybe we'll drop that 5-FU by 20%, or have a feeling they're getting some neuropathy that's grade 2 now, let's drop the oxaliplatin by 50% or 25%. It's not really done in terms of just clinical judgment alone. You do have to follow the algorithm in combination with the clinical judgment in order to be able to adequately dose patients. Of course, there is concern regarding biliary sclerosis, which is a main complication of this treatment, then an MRCP is needed to outrule this. And if that's identified, of course, we don't go back and we treat those patients. So yeah, just an idea of how the dosing is done. We don't typically see systemic toxicity with this regimen because it's minimal systemic toxicity. Of course, you have to also manage the systemic chemotherapy that is usually co-administered with this, which for biliary tract cancers is usually gemcitabine with oxaliplatin on a Q2 weekly basis. And of course, you have to be able to combine your assessment of systemic chemotherapy toxicity with HAI chemotherapy toxicity specifically to optimize treatment intensity for the patient. So I'll hand back to you, Bas, I think, on that.
Thank you, Maeve. Wonderful overview. So when I came back to the Netherlands after my fellowship at Memorial, there were actually already 2 trials published and 1 trial ongoing that investigated this treatment for liver-confined intrahepatic cholangiocarcinoma. And just to clarify, when I say liver-confined, it means that there's no extrahepatic disease, but we do allow local regional lymph nodes because in the locally advanced disease setting, they do not influence prognosis. And what is interesting about these 3 trials that have now been published, the most recent one by Andrea Sursek and JAMA Oncology, is that, and they all differ slightly in study design, but they very consistently show a response rate in the realm of 40 to 60%. And they all consistently show, and I think the median overall survival is not the most striking. I think the most striking is the 3-year overall survival. So they also show a consistent overall survival of 30 to 40%. And again, just for analogy, the slide that Maeve just started with, the subgroup analysis by Angela Lamarca of the ABC trial published in JNCI, in this prospective cohort, the 3-year survival with gemcis alone was only 3%. And just another thing to one more clarify, I think Maeve pointed it out, but we cannot say frequently enough that HAIP chemotherapy is always in combination with the systemic treatment. So it doesn't come instead of systemic treatment, it's an additional local regional treatment. So with this data, one of the main criticism has been that all these trials were from Memorial, and so it has not been validated outside Memorial. So that was kind of my first task when I came back to the Netherlands. So we set up the Pump 2 trial. We started with colorectal trial, so that's why this is the Pump 2 trial. And since this treatment is highly centralized, we ran the trial only in 3 centers, 50 patients. And in only a very short period of 2.5 years, we enrolled all those 50 patients. And this was Amsterdam, Utrecht, and Rotterdam. I wouldn't even call us high volume centers like a place like Sloan Kettering. I would call us intermediate volume. So we really included everyone who was eligible. It was really all comers. And it was the inclusion criteria we talked about. And our primary endpoint at the time was 1-year overall survival. And we compared it to a historical cohort from Amsterdam and Rotterdam with a 1-year survival of 50% of those patients, also with unresectable liver-confined intrahepatic cholangiocarcinoma, who had received only systemic treatment with gemcis. And so what was the treatment in the protocol in this non-randomized trial? It was HAIP fluoxuridine, 6 cycles of 1 month each. And after that, we discontinued, even though Memorial typically they continued with treatment. Our medical oncologists felt more comfortable to stop after 6 months treatment. And the treatment was combined with GemCis, systemic GemCis, and those patients were also allowed to be included after they already completed GemCis treatment, and then they only had pump treatment. So these are the baseline characteristics. So I think a very typical population, median age of 65. Typically, these are patients with large tumors, and 2/3 had multifocal disease. And all guidelines do recommend against resection in patients with multifocal disease. So the combination of these things it's really convincingly a cohort with unresectable disease. Nodal status was not known in all patients, but in those it was known, it was positive in 34%, and about 1 in 5 had previous systemic treatment with GemCis. So if we then look at the treatment and the complications, because at the time one of the main challenges was to actually be able to deliver the treatment, because it's not rocket science to put in a pump. Let's say it's easier than a robotic Whipple or a robotic hemiapectomy, but it's something you have to do consistently, very carefully. There are many different ways of doing it wrong. And so we did, in about half of the patients, place the pump robotically. This was typically based on the availability of the robot, because we did not want to wait too long with start of treatment. And all centers have a limited numbers of robots available. I think we were very happy that we were able to replicate a very high proportion, 96%, that actually started HAIP chemotherapy. So there are many hurdles where things can go wrong. Almost all patients started treatment. And so because some patients already had GemCis, 78% had concurrent GemCis. And just to show the success of treatment delivery, 84% had at least 4 cycles. But again, this is a treatment that requires surgery for the pump placement. And even though all patients started with pump treatment, 11 patients did have postoperative complications. This could be a pump pocket infection. This could be an abscess. The most important thing is that all those complications were completely resolved with a reintervention. And Maeve already pointed out one of the main concerns of this treatment is biliary sclerosis. And interestingly, these patients, because they have such a huge mass in the liver, many of them, before they start treatment, already have a very abnormal liver lab. And during treatment, rather than the liver lab getting worse because of toxicity, it actually improves because of the high response rate. But there was one patient that did require a stent, an endoscopically placed stent for biliary sclerosis. So these are the patients who had the complications that were all resolved. And some of the pump specific is that the pump can flip upside down, which requires a minor reoperation. It's only in the subcutaneous area. A pump pocket infection, for which we can move the pump. We can put a new pump on the other side of the abdomen, use the same catheter. One of the 2 feared complications are hemorrhage and arterial thrombosis, and actually also bile leak. Unfortunately, not 0 rates, but they did happen. But again, they were all resolved. So what about the response rate? And remember, the response rate with GemCis is only 20%. And if you add durvalumab or Pembro, it goes up maybe to 25%. So these are much more impressive response rates. 46% had a partial response as measured by RECIST. At 6 months, 88% had disease control. And consistent with Memorial data, about 1 in 10 patients did undergo a resection. And of those patients, which were 4 in our cohort, actually 1 patient who had 2 lesions, one of them more than 10 centimeter, and he had a complete pathologic response. And another patient with a similar huge lesion had a residual disease of only 1 millimeter. So what about overall survival? We compared the overall survival here with the Amsterdam-Rotterdam historical cohort of consecutive patients who received GemCis alone. And this curve is very similar to SEER data and ABC data. And as you can see, clearly superior survival. I think also 1 year survival is very clearly superior. And I really think that is, if we look back at the Dutch data, a lot of patients, they do progress quickly in the liver, and then the liver tumor grows into the liver hilum, causing very difficult to treat hilar biliary obstruction, but also in many patients, just replacing the entire liver and causing liver failure. But I think these results are very impressive. But again, this is not a randomized trial. This is a comparison with a historical cohort. All patients had at least 2 years follow-up, and we had no loss to follow-up. So if we compare this trial with the previous slide I showed you, and one of the criticisms of the Memorial trial was that all those patients either have a private jet or have a house on Park Avenue. But I think our study showed that in intermediate volume centers in a country with universal healthcare coverage, where we enrolled almost all eligible patients, we can reach very similar results. And we're currently in the process of doing a patient-level meta-analysis, combining the patients of these 4 trials, and all of them with updated survival. And this is unpublished data, but we found a 5-year survival of 15%. And if you realize that most of these patients have involvement of all inflow or outflow, and 2/3 have multifocal disease, it's surprisingly close, this 15%, 1/5, to the 30% that you can achieve with resection of an earlier stage of disease. So I think this is very impressive, even in the era of immunotherapy. And one more thing I want to add about the current standard of care of systemic treatment. My hypothesis is that if we combine systemic treatment with immunotherapy together with hepatic arterial infusion pump chemotherapy, the survival benefit will be additive. Because the immunotherapy probably better controls the disease everywhere in the body, but the best way to control the disease in the liver is with local regional treatment. So there are 2 ongoing trials from the US. They're doing a randomized controlled trial for intrahepatic cholangiocarcinoma for unresectable disease, basically the setting we're talking about. And in Rotterdam, we also participate to that trial. And in Rotterdam, we're currently also doing this treatment in the adjuvant setting, because of those patients, about 1 in 6 who do get a resection, the vast majority will recur in the liver. And the objective of this treatment is to reduce that probability. So just to get back to our patient, and I'm sure those of you treating these patients, this may look like a familiar CAT scan. So this patient started with, this was before our pump study. So this patient started with 9 cycles of Gemcis with a dose reduction after 5 cycles, and then had stable disease. And then it was one of our first patients in our pump trial, robotic pump placement, 6 cycles, and a response of 20%. And 20% is not that much, but in fact, it's already successful if you achieve stable disease in the liver, because the goal of this treatment is that you want to avoid that the patient dies from disease in the liver. And the reason we put in this slide about the 10% cure rate after resection, it's important to realize that eventually all these patients, even the ones with resectable disease, will die from peritoneal and lung and bone disease. But the local regional treatment assures to control the disease in the liver. So at the time, this was one of our first patients, we removed the pump after treatment, but very quickly in the trial, we realized many patients did not want us to remove their pump, even though it felt like an uncomfortable subcutaneous mass. They wanted to keep it because if it would progress again, we could redeliver pump chemo, but we could not do that in this patient. And of course, eventually the disease progressed, but quite late. I mean, this was 1.5 years later, new lesions developed in the liver. So later in the trial, we would have restarted pump, but because the pump was out and you cannot put it back in, there is an alternative a local regional treatment that I think does control liver disease pretty well, which is CERT or Y90, so internal radiation. And this kept things stable for another year. And then again, realized the disease is still only in the liver. Disease progressed again in the liver. And this was meanwhile 3 years after the initial GEM-CIS. So GEM-CIS was restarted until bone marrow toxicity. Another year later, again, no extrahepatic disease, but new lesions in the liver. So I think meanwhile, like currently, a patient like this, definitely in the US, would be considered for a liver transplant. And we're working on protocols for that as well in Europe, but there's no, in Eurotransplant regions, there's no protocol for that yet. And the patient continued to be very fit. He was a teacher, he continued to be teaching, and this was like almost 5 years after treatment, after diagnosis. Then the patient progressed in the liver, developed painless jaundice, and the best way to treat these patients is with percutaneous stents, because there's no need to cross the ampulla, and we don't leave an external drain. We seal the tract, and this kept things stable for quite a while. So I think what this shows really well is how you can extend survival without drugs, basically just with like best supportive care, but best supportive care including things like adequate biliary drainage. And in the end, the patient did develop bilateral complete obliteration of the portal vein, esophageal varices, ascites, and died a few months later. So I think this is one of the patients where local regional treatment really showed prolonged survival in the absence of systemic disease. The objective again of this presentation was not only because this is a great platform, the Precision-BTC collaboration in itself is already interesting to share in a webinar treatment and research plans. But in particular, I think we would like to point out that we're currently working with an international team on a Horizon grant to do HAIP chemotherapy across many centers in Europe. There are already a few centers in Europe, such as Oslo and Zurich, who offer this treatment. Oslo in Norway, Zurich in Switzerland, and there are about 10 centers in the Netherlands that currently do our clinical trials. It's currently only done in clinical trials in Europe because the drug fluoxetine is not registered. So part of this Horizon grant, we not only want to do the definitive RCTs, both for liver-confined intrahepatic cholangio and also for unresectable colorectal liver mets, but we also want to, together with industry, together with all stakeholders, get the drug registered, get the pump approved and registered, and get all centers that are interested. And we already have more than 30 centers interested in most countries in Europe to participate in these trials. And before centers can participate in these trials, we offer proctoring and preceptorship, and that's one of the work packages that Maeve is leading to make sure that the centers, which is not only the surgeon or the medical oncologist, but the entire team, is properly trained for state-of-the-art delivery of this treatment. And if you're interested in participating in this trial and you're not in touch with us yet, this is our email address, europump@erasmusmc.nl, or you can reach out to Maeve or me myself. So in conclusion, it is important to realize the chance of cure is only 10%. And I think it's so important because these patients will eventually die from extrahepatic disease. But that sets the stage for local regional treatment. The chance of 3-year survival, which I think is way more informative than median survival, because usually median survival is quite inaccurate. 3-year survival is just really rare with GEM-CIS alone, but it's getting better when you add durvalumab, up to 15% with the publication this year in Journal of Hepatology. And very important, I think this is one of the most important outcomes to understand this disease, this MD Anderson paper, where even if you look at those with extrahepatic disease, if you look at all comers, liver disease is the cause of death in most patients. So what does HAIP chemotherapy offer for unresectable liver-confined intrahepatic cholangiocarcinoma? Very consistently across trials, a 3-year survival of 30%, a 5-year survival of 15%. And in the expectation that these numbers are additive if we had immunotherapy, because this is without immunotherapy, I think the results have much room for improvement, and several centers are currently exploring to combine those treatments. We have shown in the Netherlands that this treatment is safe and feasible outside Sloan Kettering. So it's not a treatment that only works in Sloan Kettering. It's not a treatment that only works in patients who somehow make it to Sloan Kettering. It also works in the Netherlands with universal healthcare coverage. But we are aware that there's no RCT, and RCTs are required. And ideally, we do this European-wide because it's a rare disease. Thank you so much for your attention.
Bas, we have a couple of minutes for questions, I think. And we've one already in the chat from Dr. Erman Akos. So we have two questions. First, two great questions. First, what are the advantages and disadvantages when we compare this approach to other local regional therapies? So TACE, SBRT, TAR. And I suppose the other extension to that is, can this be sequenced with those treatments? You know, is there one that we should start with first? Because of course there are technical issues to placing the pump after a patient has had TACE or SBRT potentially in terms of toxicity and feasibility of pump placement, right?
Yeah, I think that's a great answer. If I may start addressing it, I think that's why in this talk I really do focus on the number one takeaway from this presentation is that local regional therapies are important, specifically in this disease. The short answer is that we do not know the answer because there's no head-to-head comparison. On the other hand, if you do look at what's available, and there's a great systematic review of Julien Edelin looking at all local regional treatments, and in the absence of randomized controlled trials, the results are really most promising for HAIP chemotherapy. There are a few downsides about the other treatments. SBRT, for example, I think SBRT is feasible if it's a relatively small lesion. Again, many of these lesions are like 15 centimeters, and very often it's multifocal. Sometimes there are 10 lesions. So even though you'll always find a radiation oncologist who will say, we can do 15 lesions, or we can do a 15 centimeter lesion, I think it's not optimal. But I think if you have a 5 centimeter lesion in the hilum of the liver, I think SBRT is probably a good alternative, definitely in the absence of HAIP chemotherapy. I think all the intra-arterial treatments, I think the most promising results are from SIRT. So especially from the MISFAC trial and the recent kind of head-to-head comparison with the ABC trial results in hepatology. I think it works. But again, it doesn't treat the whole liver, so it doesn't treat the lesions you don't see, and it's more difficult to treat many lesions. And finally, the CIRCA trial, which is the only randomized trial that compared systemic treatment with or without SIRT. The trial has not been published, but the results are available on clinicaltrials.gov. And the survival is the same, which to me is surprising. And I think that paper really needs to be published. But so in summary, I think that by far the most promising results and the most replicatable results are for HAIP chemotherapy. But I think there's something to say for all regional treatments, and there is probably a way of combining those. And your second question, should we add IO? I think we should, and that's currently being done. But it's kind of, although there's no immediate reason, as far as I can see, to be concerned. But maybe Maeve can say more about that. That there may be like some additive toxicity when adding immunotherapy. I know several people started doing this, and probably several centers have like treated patients with the combination, like maybe 20, 30, 40 patients, that realm in the US. But I haven't seen any results published on the combination yet. Maeve, what do you think?
No, we don't have data on that as of yet. I mean, obviously, combination immune checkpoint blockade with local regional therapy has been very successful, especially in HCC, right? So it's an attractive idea to combine. We do have to do these in a prospective manner, ideally, because a cautionary note comes from trials of the addition of bevacizumab to HAIP, which resulted in significantly increased levels of biliary toxicity, totally unexpectedly. So, we do need to do it prospectively and record the outcomes and the toxicities of that. There are studies, particularly from Asia, of combining immune checkpoint inhibitors with hepatic arterial chemotherapy, not FUDR, for HCC, which have shown that approach to be safe. So I think it just needs to be done in a prospective manner and the toxicity is adequately recorded for us to know that. We don't have enough data, I would say, our patients treated with intrahepatic cholangiocarcinoma, HAIP, and no results from that as of yet. Certainly people will be doing it. And one last question I see from Rocio here about the pump study, Bas, in terms of minimum numbers that are required per center to participate. Is it 1 member per center? How many people do we need? I mean, we certainly need 1 surgeon and 1 oncologist for sure.
That's the key answer. That's the key answer. And that's also maybe why it's not so easy to implement this treatment, because it's really a treatment of where you need close collaboration of a surgeon and an oncologist. And what I understand in the US. So in the US, it used to be Memorial and maybe 2 other centers. Currently, almost all cancer centers in the US have a pump program. So I've recently been told that the top 10 US cancer centers all have a pump program, but some of them it took a while because sometimes only surgery was enthusiastic about it, sometimes only oncology, but you really need the collaboration. And depending on your volume, you can have 1, 2, or 3 surgeons. But I think as a rule of thumb, if you want to set up a pump program, and it's a rule of thumb, nothing more, but I think you should probably have about 100 liver resections per year for any indication to give you sufficient patients that we anticipate would be eligible for pump. Because I think this treatment, because of some complexity issues, you would probably want to do at least 1 a month. And I think you can do at least 1 a month if you have about 100 patients in whom you do a liver resection. What do you think, Maeve?
Yeah, sounds reasonable. Yeah, I think so. I think we're just about at time. Are there any other questions?
I did see, so I did not address Erman's topic about the chemosaturation. So if I understand correctly, I've never done or seen chemosaturation, but I think this was a treatment that was done, I think, a lot in the 80s and 90s for liver tumors. Actually, mainly in Leiden in the Netherlands and in Pittsburgh, where they did isolated liver perfusion. The way fluoxetine does it, because the drug is completely metabolized in the liver. There's an alternative way, just like you can do isolated limb perfusion for melanoma, is to isolate the liver surgically. But both those centers who are really leading this stopped doing it because of a very high morbidity and also very high mortality rate. So as far as I know, chemosaturation, for example, with melphalan, is rarely or not done anymore.
Any other questions? that's all we have. So just to say thank you to the Precision-BTC Network for accommodating the webinar today, and to emphasize myself and Bas are happy to chat further around the opportunity for the grant, around what we'll discuss today. And you have the emails there to, I think, to connect with us if you want to discuss any further.